Thank you for the opportunity. So I'll get straight to the topic. Do we have a time or the timer set? Okay, thank you. So I'd say I'd classify arrhythmias into two types: the malignant ones and the ones which are emergency ones. Uh, I'm putting this practical classification. Malignant, I say the patient is going to die or something really nasty is going to happen to the patient very, very soon if you don't treat that arrhythmia very, very quickly. And the others, of course, I think emergency is basically anything that causes severe symptoms. The reason I put it this way is, in a malignant arrhythmia, more important than the arrhythmia is what is happening to the patient. Meaning, promptly treat the arrhythmia. Do not waste too much time trying to figure out what the arrhythmia is. Don't try to waste too much time looking at the ECG. Is it SVT? Is it VT? Is it this? If it's a arrhythmia which is malignant, you first shock and then think. So that's that. Now that we are done with that, we'll look at the arrhythmias where we get time to think. There may be bradyarrhythmias and tachyarrhythmias. Rate less than 60, rate more than 100. Bradyarrhythmias may be due to sinus node dysfunction or AV block. And tachyarrhythmias can be narrow QRS or wide QRS. Both can be either regular or irregular. So I'll first come to bradyarrhythmias. Now, once again, I'd classify arrhythmias from a practical standpoint. The ones where the patient is collapsing or almost collapsing and where the patients have symptoms. Now, in the absence of symptoms, there is no emergency treatment required for a bradyarrhythmia. If a patient comes with a sinus rate of 35 and patient comes walking to you, there is no emergency to put him in the ICU and start some treatment. Patient comes with a junctional rhythm, he has no symptoms. There is no emergency there. Patient comes with a CHB with a narrow QRS escape rate of 40. Patient is 35 years old. There is no emergency to suddenly treat this thing. So, by and large, bradyarrhythmias which are absolutely asymptomatic is not an emergency. So, if a patient is nearly collapsing, start CPR. Think later. During the CPR, give atropine. Might repeat it. And if it doesn't work, or while you're doing it, get ready for temporary pacing. Transcutaneous pacing. If you have the facility, good. Sometimes it works, sometimes it doesn't, to be honest. But if you have the facility, don't forget to think about it. And then you have to go to transvenous pacing. So that's when the patient is really collapsing. If the patient is not collapsing, then you think, is this a sinus node problem or an AV node problem? If there's a sinus node problem, again, you go to atropine. And most sinus node problems will recover with isoprene and stopping the offending drugs. They rarely require pacing. An AV node problem, you have a narrow QRS escape rhythm or a wide QRS escape rhythm. A lot of narrow QRS escape rhythms are reasonably stable, except there are some patients who have diastolic dysfunction or an underlying bad heart. There, they don't tolerate AV block. But if the underlying heart is structurally normal, most patients will tolerate a narrow QRS escape rhythm, which means it will give you time to try atropine and isoprene and only then go on to temporary pacing. A wide QRS escape rhythm, you give atropine while you're getting ready for temporary pacing. You don't give atropine and wait for the response and decide whether you want to do temporary pacing. The patient comes with a symptomatic wide QRS escape rhythm while you're getting ready for temporary pacing, you might give atropine. But otherwise, just go straight to that. If there is a sinus node dysfunction, make sure there is no acidosis that is correctable. It may be rarely a presentation of an inferior MI. Make sure there is no acute renal failure. If there is an AV node problem, in addition to these, also look for hyperkalemia before you jump to the final conclusion. So, obviously, you need to identify what the ECGs are. There may be sinus bradycardia, which is slow sinus rate, which I think all of you will be able to identify. There may be absent antegrade P waves. Here, all the P waves are after the QRS complexes. So, it's a junctional rhythm with a retrograde P wave. And that's AV block with a wide QRS escape. This is the one where you start getting ready for temporary pacing and you start thinking of the treatment while you're getting ready for temporary pacing. And you have the AV block with the narrow QRS escape where you do the reverse. You start treatment and then decide whether you want to do temporary pacing. Unless the patient is going into heart failure or something, you often don't need temporary pacing here. So that's about bradyarrhythmias. Finished. Now we'll come to tachyarrhythmias. Tachyarrhythmias, again, you have patients who are nearly collapsing and the patients who are symptomatic. It is very rare to have a tachyarrhythmia where the patient has no symptoms. So, the first thing when you have a tachyarrhythmia is see if you can see a proper well-formed QRS. If you cannot see a well-formed QRS and if the patient is nearly collapsing, stop thinking, start shocking. Don't think of what energy to give, how much to give. Just give the maximum energy that the defibrillator can give and think later. then you have a well-formed QRS visible. Remember, this patient is almost collapsing. Please don't try to figure out if it's SVT or with aberrancy or VT or anything. A patient is significantly symptomatic. There is a wide QRS arrhythmia. If there is a pulse, if the next thing you do is see if there's a carotid pulse. If there is a carotid pulse, you give a synchronized cardioversion. So very important to synchronize. That is, you have to press the sync so that the sync markers come. Make sure the sync markers come there and only then shock. Giving an asynchronous shock in this situation can convert a well-formed arrhythmia into a ventricular fibrillation. So you might shock the atrial fibrillation also. The top tracing is atrial fibrillation, but the patient is significantly symptomatic. So the treatment remains the same. You give a synchronized shock. And sometimes you're not sure of the QRS morphology. You're not sure of the carotid pulse, or you think there is no carotid pulse, but if the patient is nearly collapsing, you shock first and then think later. Don't go to the other extreme. If the ECG looks horrible, but the patient is talking to you, patient looks okay, meaning you have a stable patient, but what I call an unstable ECG, this is usually not an arrhythmia. It's usually an artifact. So the clue is, if you look carefully, you can see these well-formed QRSs at regular intervals in them. So important thing is look at the patient and then look at the ECG. Now we come to the patients who are symptomatic but not collapsing. First step is, please record a 12-lead ECG. Don't treat based on a strip. Okay, a 12-lead ECG might show a regular narrow QRS tachycardia. But if at all the patient gives you 2 minutes to record this ECG, even if it's a wide QRS tachycardia with just about enough blood pressure, please record this ECG before going on to the final treatment, the next treatment, because this one ECG will provide multiple very important clues on how to do the long-term management of this patient. So if the patient is not collapsed, please record a 12-lead ECG. That will tremendously help the cardiologist or the electrophysiologist who has to come up with a definitive management for this. So now, wide and narrow QRS. Why do we call this wide and narrow QRS? Because more than 95% of narrow QRS tachycardias are SVT. That's a simple reason why we classify them as wide and narrow. So there are two types of SVT. The ones that start in the atrium and go down to the AV node, and the circuits which travel between the atrium and the AV node. Mechanistically, it's easy to think of it this way, treatment-wise. So there are three SVTs which start in the atrium and go to the AV node. One is sinus tachycardia. When the focus is somewhere else, it's atrial tachycardia. When it's a continuous focus, it's atrial flutter. But mechanistically, these start in the atrium and go down the AV node. And then there is an irregular tachycardia, one irregular tachycardia starting in the atrium from all over the atrium and going down the AV node, that's atrial fibrillation. So 4 starting in the atrium and going down the AV node. Now, the one starting in the atrium and going down the AV node, next important thing is look at the shape of the P wave. Here you can see that the P waves are positive from V1 to V6, which means it's coming from a posterior structure, which means it's coming from left atrium, so that's a left atrial tachycardia. It's very important to understand the morphology of the sinus P wave. The sinus node is located in the superior and the posterior part of the right atrium, and the right atrium itself is an anterior atrium. It's not the posterior atrium, which means that the sinus P waves will be negative in AVR and positive in all the other limb leads. It will have a negative component, it will have an initial positive component, and then a negative component in V1. So V1 is here, it will activate the right atrium towards V1 and then the left atrium away from V1. So initial positive and subsequent negative in V1. It's very important to understand that whether something is sinus tachycardia or not, because when you have sinus tachycardia, you treat the underlying cause. When you have atrial tachycardia, you treat the tachycardia. The underlying cause is there in this ECG. I won't come to that because that's not the point of the discussion. You don't treat this tachycardia, you treat the underlying cause. This is pericarditis. Atrial flutter is where you don't have gaps between P waves because it's a continuous activity. You see these sawtooth P waves, best seen in 2-3 AVF, and there are no gaps between P waves. Atrial fibrillation, of course, is irregular and you can't see the P waves. So now we made all the diagnosis of all the 4 tachycardias starting from the atrium and going down to the ventricle. And then we have the tachycardias which reciprocate between the atrium and the ventricle. By and large, in these tachycardias, you don't see the P waves. So unless proven otherwise, if you have a regular narrow QRS tachycardia and you don't see the P wave, you assume that this is an AV node dependent tachycardia and treat as a re-entry. Sometimes you can see a P wave. When you see a P wave, it can be an AV node dependent tachycardia. That is, this P may be going to this QRS and this QRS may be going to this P. Or it may also be an atrial tachycardia. This P may be causing this QRS. this QRS may not be going up to this P. There is no way of conclusively knowing that from the ECG. So from a simple standpoint, treat it as a re-entry. If that doesn't work, well, your diagnosis is wrong, then you treat it as an arrhythmia from the atrium. So that's how you go about it practically. It's a different thing when you're going through an ECG class. Here we're talking about how to manage an arrhythmia. So next thing is you have to figure out how to treat a re-entry, that is an arrhythmia which goes through the AV node. First thing is carotid sinus massage if there is no bruit. But then this is practically impossible. Who can make out a bruit in a patient where the heart rate is 170? Not me. So generally, you just give a carotid sinus massage if you think that there is very low risk of a carotid plaque. If you think there's a very high risk, you don't give a carotid massage. You give adenosine, and if that doesn't work, you give diltiazem, verapamil, or metoprolol. And very rarely, if it's a symptomatic, severely symptomatic patient, you cardiovert. Sinus tachycardia, you treat the cause. Atrial tachycardia, first drug would be beta blocker, followed by either flecainide or sotalol or amiodarone, and if unstable, cardioversion. Atrial fibrillation, you first try AV nodal blocking drugs always, before you don't have to jump and go to amiodarone to all the patient. If that doesn't work, then you go to getting rid of the arrhythmia. Atrial flutter, by and large, drugs don't work, but if you want to give one drug, that would be ibutylite. This is very important. I'm not going to go through this, but you must know the drug doses used for all SVT. I'm not going to go through this in detail. You can, but you must know that these are the standard dose of drugs used for treatment of SVT. Now coming to adenosine. Put a large IV line, flush rapidly, and please record an ECG strip during adenosine, not before adenosine, after adenosine. All the information is contained in that ECG strip during adenosine. So here is where there is a QRS and a P. You can see that when the tachy is terminated, the QRS has not gone to the P. So by and large, if you see this is an AV node dependent tachycardia because the QRS not going to the P has stopped the tachycardia. Here you can see during adenosine, an atrial flutter has been unmasked. There are multiple P waves which are continuous with each other. So you unmasked an atrial flutter during adenosine. And here you can see it's a little confusing thing. There is a P and a QRS, and when we give adenosine, there is no P. So this is an AV node dependent re-entry. This is an atrial flutter. This may be an AV node dependent re-entry, that is adenosine may have stopped this QRS to conduct to the P, or it may be an adenosine sensitive atrial tachycardia. About 8 to 10% of atrial tachycardia are sensitive to adenosine. So just because something stopped with adenosine, that doesn't mean it's dependent on the AV node. But here is a practical example of why you need to use record during adenosine. This is a patient with RV cardiomyopathy, came with some symptom and a BP of 110/80. Not sure what is his tachycardia, we cannot see the P waves. You give adenosine, this happens. P waves with multiple isoelectric intervals in between, and so that's an atrial tachycardia. And a short while later, it starts and goes back to the original tachycardia. So if you had to record an ECG during adenosine, before adenosine, after adenosine, it will look the same. And very often you come to report saying adenosine did not work. But the whole information is during adenosine. So please record ECG during adenosine. And if there is no change with adenosine, but you think it should have worked, there is no, it looked like a reentrant tachycardia, then think of whether you gave adenosine the wrong way or the wrong dose. Give up to 18 mg after cutting down sympathetic stimulation. A highly sympathetically activated patient, adenosine may not work. Sedate the patient deeply and then give 18 mg of adenosine, preferably through a central line or at least an external jugular vein. And that, if that doesn't work, then you say, okay, now adenosine did not work. But before going through this step, don't say that adenosine did not work. SVT reverts with adenosine but comes promptly. Now what to do? Well, if you have center which you can ablate, you go ahead and ablate. But if not, you give a drug which will prevent reinitiation of SVT and then repeat that adenosine. So I would give a diltiazem infusion for about half an hour or so and then give the adenosine on top of that infusion, and very often it will stay reverted if you do it that way. Of course, this is atrial fibrillation, irregular narrow QRS tachycardia. You could chemically or electrically cardiovert, or you could opt for rate control if the patient is stable. But what I want to tell is that, see, the risk of embolization is there with chemical and electrical cardioversion. Don't think that you give a shock and the clot will go to the brain, and you give amiodarone and it will terminate, the clot will not go to the brain. So the risk is in the substrate. The risk is not necessarily in the arrhythmia itself. Okay. So if a patient has an atrial fibrillation of unknown duration, please don't jump to give amiodarone before you sufficiently anticoagulate the patient. That is what I want to tell here. So if, while giving amiodarone, please look at the blood pressure. If the blood pressure is on the lower side, please do not give that bolus of amiodarone. If you want to, if you still insist on giving amiodarone, you can give a low dose. I'd rather cardio if the blood pressure is on the lower side. Personally, I'd prefer ibutylate for flutter and amiodarone for AFib because I found that that's the way it works better. Before cardioversion, please start a noradrenaline because you have to sedate for cardioversion. Once you sedate, the BP is on the lower side, you want to cardiovert. And if the BP is on the lower side, when you sedate, the BP is going to crash. Anticipate that, start NORAD and then sedate and then cardiovert. If a patient has some significant ventricular dilatation or atria are significantly dilated, it is better to initially load with amiodarone if possible for 1 or 2 days and then cardiovert. That enhances the success of cardioversion. So don't jump to cardiovert. Chemical cardioversion of atrial flutter, ibutylate. If it works, it will work in 15 to 20 minutes. If it doesn't work in 15 to 20 minutes, usually it will work in 5 or 10 minutes. If it doesn't work in 15 to 20 minutes, it's not going to work. If it works, it's beautiful. Give it one shot. If not, well, go to the next step. Now coming back to that patient, this patient, we just give beta blocker, got the rate down, got the patient to be comfortable, and then took him to the lab and ablated the atrial tachycardia. So I'm just saying that there are different ways of dealing with it. It's not that every patient should have rate control, every patient should have rhythm control, every patient should have cardioversion. You individualize it. By and large, in stable patients, I would prefer to give rate control, study the arrhythmia, and then come up with a long-term plan. Now coming to the white QRS tachycardias. I'm not going to go through how to differentiate white QRS tachycardia into VT and SVT. That's not the purpose of this talk. I'm talking about the management. So we have this white QRS tachycardia already diagnosed as ventricular tachycardia. Now what to do here? If the BP is reasonable, I would always give drugs. I would always give drugs time to wait, time to act. And the most important thing in drug is give as much beta blocker as possible. And then give a small dose of amiodarone. At the same time, I wouldn't continue this drug for a long time because when you terminate it, you might end up with bradycardia. So it would be reasonable to give amiodarone something like overnight and then go into cardioversion rather than cardiovert straight away. And in that time, you get time to anticoagulate, you get time to look at other things, whether any underlying precipitating factors, what is the LV like, what is the atrium like, is there mitral regurgitation, what's the patient like. Also look at triggers for ventricular tachycardia, hypokalemia and ischemia. Now, I want to tell this very clearly. Most regular monomorphic ventricular tachycardia are due to scar and not due to ischemia, which means that if you have a patient with a ventricular tachycardia which is monomorphic and you find a coronary artery disease, most likely that coronary artery plaque, what you found, is not the cause of the ventricular tachycardia. I'm not saying that that plaque doesn't need treatment. Don't assume that if you treat the plaque, the ventricular tachycardia will go away. If it is a regular monomorphic ventricular tachycardia. Troponin may be positive because the VT caused hypotension or because of cardioversion or because of ischemia due to the VT. A troponin positive with a VT doesn't mean that it's an ACS causing VT. If ischemia is present, it is often difficult to decide whether the ischemia is the cause of the VT. You have to treat both. But I'm just saying that if you find a coronary artery disease and a VT simultaneously, don't always assume that if you treat the coronary artery disease, the VT will go away, especially if it's a regular monomorphic ventricular tachycardia. Now, another situation of treating the underlying cause. Permanent AF on diuretics, sudden recurrent loss of consciousness. Obviously, it's a polymorphic VT, it's a Torsades, and the reason is here, it's hypokalemia. It's a QT prolongation due to hypokalemia. So, you need to stop the drugs, give some empirical magnesium, and then treat it. So, the only safe drug in this situation is lidocaine. And this is the dose of lidocaine. But by and large, these things will respond to magnesium and correcting the underlying precipitating factors. It's the usual precipitating factors, too much diuretic. What if the arrhythmia recurs after cardioversion? Now we have a problem. You have cardioverted, that's your last therapy, and the arrhythmia has come back. If it's an SVT and the patient is stable, you usually have time. You can start some IV diltiazem, might start amiodarone infusion, and consider ablation. At this stage, refer the patient promptly for ablation when the patient is still stable. Don't wait till the patient starts crashing. But what if it's a VT which has recurred after cardioversion? Please don't keep the patient there and try one drug after another drug till the patient becomes unstable. If a ventricular tachycardia has recurred after cardioversion, please send the patient for ablation. Please start making arrangements to send the patient for ablation. rather than keep the patient for 1 or 2 days and try multiple, it can really become nasty. And very important thing, keep the defibrillator patches connected to the patient. Don't waste your time to bring the defibrillator, put it on the patient, shock. Those 2 minutes may be the difference between life and death. So if a VT recurs after cardioversion, keep the patches connected on the patient so that next time the VT comes, at least you can shock promptly and start making arrangements for ablation. So here is another point I want to mention. So here's a person who had a surgery for a tetralogy fallow and came with a ventricular tachycardia, was cardioverted. A little later, the ventricular tachycardia recurred. BP is now 160, it's not too bad. Okay, another morphology of ventricular tachycardia, each way cardioverted. Now, next ventricular tachycardia is 60 blood pressure. Now, at this point, please do not try one drug after another drug. At this point, the patient is still reasonably stable enough to transfer for ablation. But you keep this patient, try one drug after another drug, then you have a point of no return where the patient is hypotensive. Already the LFT is bad. Now the renal output will reduce, and then it's gone. Then you ablate, the tachy goes, the patient also goes. Not because of the tachy, but due to the hemodynamic compromise suffered while the patient is getting ready. So, and very importantly, implantable cardioverter defibrillator is not the treatment for recurrent ventricular tachycardia. If a patient gets an ICD for secondary prevention for VT, it should, I think, be standard practice, like we do, to observe the patient for 2 or 3 days before deciding to implant the ICD. That's at least what we do in our center. Patient comes with a VT, scar-related VT. We cardiovert the VT. We keep the patient there in the ICU on only beta blocker and see for the next 3 days if it's going to recur. If it is going to recur, please ablate and then implant the ICD. The worst thing that a patient can get is to get recurrent ICD shock. So you want an ICD to shock, but you don't want it to shock too frequently. So before you put an ICD for secondary prevention, make sure the patient is in a state where he's not going to get recurrent shock. Simple thing is, keep the patient only beta blocker for 3 days before deciding to implant the ICD. If he has a recurrence, please don't implant the ICD. Ablate and then implant. Now, what if the arrhythmia does not respond to cardioversion? That is really, really bad. That's worse than what we told. So this needs an start planning for an emergency ablation, and there are some things which you should do while you start planning. Look for underlying triggers. What do you do when you plan? So this happens only in 2 situations where there is recurrent VT which is not responding to ablation. One is very, very sick patient. There the patient and the family and everybody is more or less anticipating it. Class 3, class 4 patients who've been very sick for a long time. Somebody gets recurrent VT like that. It's still, I'm not saying that it's a good thing, but it's not an unanticipated problem. The situation where it comes unanticipated is early post revascularization, especially if a patient is revascularized more than 24 hours post MI. Take a, you should have your thoughts very clear if it's going to be a delayed revascularization. That is one situation where you'll end up in this mess, and that is unanticipated. So then you have to do something. So here's something. Patient is getting recurrently cardioverted, the VT is coming back on and on. So what do you do in this situation? First thing is medical therapy. The best beta blocker in this situation is thought to be propranolol because it also acts on the central sympathetic system. Blood pressure will be low, obviously. Patient will be on high inotropes. If you have an ECMO, put the patient on ECMO. Most centers will not have an ECMO, but if you do, put the patient on ECMO at this situation. If you have an IABP, put an IABP. Simultaneously start all these things. Amiodarone is going to be hopeless in this situation. Patient not going to have any blood pressure. It's hardly going to work. Lidocaine is going to take time to work. Probably the one drug that you can try is phosphonetoin, 1 gram over 1 hour in 100 ml NS. And try rapid atrial pacing. The moment you cardiovert, start pacing. So you start with this. The next thing is, see, the sympathetic stimulation to the heart is what drives this ventricular tachycardia, recurrent VT. So you treat the tachycardia, you also cut down the sympathetic stimulation to the heart. These are all things that you do while you get preparation for ablation. And then you also try to get preparation for ablation. This would be another good resource. This is Dr. Lawrence phone number. That's another good resource in this situation. Now, what I mean to say is, don't hesitate to take help. It's a crash and burn situation. Don't try to manage it yourself. So coming back to the sympathetic modulation, now you can either, the simplest way of sympathetic modulation is deep sedation. Gently, straight away anesthetize the patient. Straight away put the patient anesthesia and make sure the patient is not woken up even for meals. Patient should not move. Straight away put the patient under gentle anesthesia. The anesthetist would be, totally against this. Patient BP is no, 60 systolic, 70 systolic. You say, no, let us stabilize. There's nothing like stabilizing the patient. Put the patient under anesthesia. This is either life or death. So anesthetize the patient and then think. The second thing which we can do is cut down, work on the thoracic epidural anesthesia if it can be done, or block the stellate ganglion if there is local expertise to do that. A good anesthetist can often do this. Give a bupivacaine infusion in the T1 to T2 or the T2 to T3 space, or get a needle and get 3 to 5 ml of bupivacaine in the thoracic sympathetic chain, which lies in the fascia of the longus colli. Can be done in 3 ways. If it's a very dire situation, just pull the sternocleidomastoid away, pull the carotid away, poke a needle down till you scrape the trachea at the C6 level and inject 3 to 5 ml of bupivacaine there. Even if you do it blindly, it will work in 50% of the cases. Or if you have time, it can be done with ultrasound guidance, with a little more refinement. You have to inject on top of the longus colli. Here you can see the carotid artery and the longus colli in ultrasound. It's not difficult to do. Or if you have access to a cath lab, do it in the cath lab. You just aim for this particular foramen. The sympathetic plexus lies in front of this foramen, just on the vertebra. It's not a complicated procedure. It takes hardly 5 minutes to do this. Once you put the needle there and you scrape the vertebra and go backwards, once you feel the needle hitting the vertebra just in anterior to this foramen, pull the needle back just a little bit, inject a little bit of contrast first. It should go up and down vertically. That's when you know that you are in the longus colli fascia. And once the contrast goes up and down vertically, then you follow it up with bupivacaine in the same area. This works in about 80% of the cases and gives you a day, almost a day's time to transfer the patient. So these are the things that you do when you stabilize the patient for ablation. In this situation, in the post-MI situation, it's very often due to peri-infarct Purkinje fibers which have become automatic. The myocardium has died, but the Purkinje fibers are not died. They are more resistant to ischemia and they can survive with blood just from the cavity. And when you're revascularized, you have woken up the sleeping Purkinje fiber, which is now no longer connected to the rest of his Purkinje system. So it becomes automatic, starts firing. So this is not an uncommon situation of delayed revascularization. If you have facilities to do, it's a beautiful therapy to do. You can ablate the peri-infarct Purkinje fibers and get excellent long-term results. So I'll stop with that. And I don't know if you have time for questions. Yeah, I think we have time for questions. Good. Thank you.